I'm Martin Roland. I'm Professor of Health Services Research at Cambridge University in England, and I'm a GP, and I've been a GP for the last 30 years or so. One of my main interests in the research that I do is how you improve the quality of primary care. We know from lots of studies around the world, not just in primary care but in secondary care as well, that there is a big gap between the quality of care we could provide for our patients and the quality of care that we actually provide. So how can we fill that gap? And a lot of work has been done looking at a range of different things that might help. So people have looked, for example, at audit, at feedback of doctors about their own performance, using opinion leaders to promote quality improvement, and using incentives of one sort or another. Incentives have become an issue of particular interest in the last few years, and there are now many countries in the world that have experimented in giving doctors financial incentives to improve the quality of care that they provide. These, for example, are now widespread in the US. The idea that improving quality of care is something that's really important is relatively new. It's a science, if you like, that has evolved certainly in the last 20 years. Indeed, if you go back 20 years, you'd go back to the first attempt by the British government to pay doctors a bonus for providing good care. And the doctors' representatives at that time, the British Medical Association, were firmly against that. And they said no to any idea of what was called a good practice allowance. And if you like, the underlying ethos then was, well, you can't measure quality anyway, and there's no such thing as a bad doctor, so why would you even bother to try? But of course we now know that neither of those things are true. First of all, a lot of work has been done demonstrating widespread variation in what doctors do. So some doctors will treat a condition in one way and others in a completely different way. And allied to that, in the last 20 years we've had the growth of evidence-based medicine showing that there are some correct ways of treating patients or diseases and some which are not. And so if you put the experience of variation in medical practice together with evidence-based practice, you then find that there's widespread variation in quality. And so some patients are getting poor quality care and other patients are getting good quality care, and that is something which any healthcare system will want and need to remedy. So that's led in the last 10 years really to a tremendous growth in the movement to improve quality of care and close the gap between what we actually provide for our patients and what we could provide, something which was called the quality chasm in a famous book published by the Institute of Medicine. So it's that quality chasm which we're trying to bridge and forms the basis for EQUIP, for this conference, and for much work around the world trying to improve the quality of care that we provide for our patients. In England we've had perhaps one of the biggest experiments in financial incentives to improve quality, so-called pay for performance, and this has now been running since 2004, so we've got 7 years experience of what happens when you try to pay doctors to provide better care. So has it worked? And this is a key question, and one which I will be addressing in the conference in Copenhagen. The answer is not a simple one. The answer is yes, financial incentives do make an impact on doctors' behaviour, but they're certainly not a magic bullet. So you need a range of things to improve quality, of which financial incentives may be one thing that can help. Especially, of course, if doctors have to pay out more money, for example, to employ more staff, to provide that better care in their practices. But if you give financial incentives, does this have a downside? Are there any problems? And again, in the UK we've now got quite a bit of experience of looking at the sorts of things that might perhaps be unexpected. All incentives can have unintended consequences, and we have some good examples where well-meaning ideas have gone quite badly wrong in the UK. We've also got examples, and we can look at what happens to aspects of care that are not incentivised. If you give financial incentives to doctors to do some things, what happens to other aspects of their care? And what happens to doctors' own motivation? What happens to doctors' own professionalism? Even now, 7 years into our pay for performance scheme, you find widely diverging views from different GPs in the UK about how good and how useful this scheme has been. There are some doctors who feel that it has been absolutely what is needed. It has helped them improve care in their practices, and it's paid them to provide what they think they should be providing to their patients: high quality technical clinical care. But there are other doctors who feel that it has really undermined what they do, and that it has led to too great a focus on clinical aspects of care and perhaps less focus, for example, on continuity of care, which is something very important for patients and for doctors, but not, in our scheme anyway, attached to any particular incentive. And so I don't think you could say there is a single view. We now have a lot of data on what the impact of the pay-for-performance scheme has been, but is it good or is it bad is a difficult question on which there are many different views. What I think is clear is that over the last 10 years, doctors or GPs' understanding of their care has changed. And in particular, we've got good evidence that what doctors understand by holistic care is quite gradually but quite definitely changing. So if 10 years ago you asked, or 20 years ago certainly, you asked doctors what they understood by holistic care, whole person medicine, they would have talked often in terms of a biopsychosocial model. So taking the patient's illnesses into account, their psychological state and their social circumstances. But this is starting to change, and doctors' understanding now of whole person medicine, they will often now describe this in terms of care for multiple chronic diseases. So a stronger focus on the clinical side of the patient's care and a less strong focus on other aspects of care, but a stronger focus on getting all those and those increasingly complex parts of clinical care right. Because of course general practitioners now see many conditions that used to be seen by specialists, and as our populations age, they have more and more chronic conditions. So I think we see that the nature of general practice and our understanding of the discipline and what it means to be a GP is changing. And I think it's perhaps not surprising that there's a wide variety of views on whether this is a good thing or whether we are losing something precious from the past. I certainly don't think that pay for performance has been the only thing which has affected that. I talked earlier about the rise of evidence-based medicine and variation in practice, which related to variation in quality of care. So there are lots of other reasons why doctors may be starting to take a different view of their job, and that's one of the important things I think for the profession to debate, is where should our care of patients be going? These are all really important issues which potentially can be altered by the way in which we pay doctors. So these are the issues that I'm going to talk about at the conference in Copenhagen. And one of the advantages of having people who've come from lots of countries is that you will all bring your own experiences of quality improvement schemes in your countries, some of which may well have financial incentive schemes as well. And so we can share from the learning that's taken place in different countries on this key and important issue of how much difference does money make to improving quality of care.